Please start. We are live.
Good evening and welcome everyone. I would like to invite you to the webinar, which is under the Aegis of Cancer Search and Static Foundation. And the meeting name is Browse, which is Breast Oncology with Scientific Expert, HER2. And for meeting starting, I would like to invite the program director, who is Dr. A.K. Vaid, Chairman Medical Oncology, Medanta Medicity Hospital, Gurugram. Um, I would like, sir, to invite the chairperson and take the following proceedings. Over to you, sir.
Thank you, Ankit. And it's an honor and a privilege to be a part of the proceedings this evening. I thank AstraZeneca, Dr. Priyanka, for the opportunity. And a very warm welcome to everyone who has joined from India, and a good evening to everyone. And a very warm welcome to our guest speaker, and a very good morning to Dr. Paola Tarantino, who's from the Dana-Farber Cancer Institute, US. And friends, we know that over the last 2.5 decades, we've been treating the HER2 positive disease, where there was a single application of the drug or the drugs which evolved over the last 2 decades in the clearly three positive or the fish positive. But our ever evolving knowledge and targeting of the HER2 signaling is expanding the horizon and our options in the management of HER2 low disease, which would be the focus of the talk of our guest speaker today. The agenda for the meeting is very exciting. We have discussions on the HER positive metastatic breast cancer and HER low breast cancer, which is the focus of the guest speaker, as I said. Also, discussion about the testing and what all we should be doing, and what is the case selection for the HER low disease, and what are the definitions around that. And of course, towards the end, there is a panel discussion on the hormone receptor positive metastatic breast cancer. I welcome you all once again and look forward to very exciting discussions. And at the end of it, I do believe and convinced that we would be able to treat our patients better tomorrow morning. Back to the organizers with many thanks once again. Back to you, Ankit. Thank you so much once again.
For the further proceeding, I would like to invite the chairperson, Dr. P.N. Mohapatra, who is a director of Medical Oncology, Apollo Cancer Center, Kolkata. Sir, would you like to invite the our moderator and panelist for the next session?
Hello. Hello.
Yes, sir, you are audible.
I think we have been. It's an excellent program. It's very thank you to be when I invite me as a chairperson. I think Dr. Batra is also there, and I think Dr. Kalra must speak something. And next speaker is a pathology. Then we'll proceed with the next session. Hello. Hello.
Yes, sir.
Uh-huh.
For the next session, I would like to invite Dr. Alok Gupta, sir, and the panel discussion is on HER2 positive metastatic breast cancer.
Right. So, a very good evening to all. At the outset, I would like to thank Dr. Vaid, sir, for organizing this academic meeting, and also for so frequently organizing these academic sessions, which always keep us updated about what is happening in the field of oncology. So, thank you, Vaid, sir. Thank you, chairpersons, for giving me this opportunity. So, let me invite my panelists, and let me also request for somebody to play my slides. So my panelists for this discussion on metastatic HER2 positive breast cancer include Dr. Priya Tiwari, Dr. Pankaj Goyal, Dr. Tara Chand, Dr. Satish Sharma, Dr. Chandru Gowda, and Dr. Arun Raja. So we'll be having 6 panelists for this discussion. So it would be a case-based discussion, which would essentially be highlighting how we are treating HER2-positive metastatic breast cancer in the year 2024. Also, throwing some insights into the evolution of treatment, the availability of newer drugs, and how we have incorporated these molecules into our day-to-day practice. Next slide, please. So the topic would cover how to choose the right therapy for the right patient, HER2 testing in metastatic breast cancer, managing breast metastasis, which we so frequently encounter in our clinical practice, and how do we sequence, given the fact that now we have so many treatment options available for this disease. Next slide, please. So let us begin with this case scenario. 55-year-old postmenopausal woman diagnosed with ER/PR negative HER2 positive breast cancer. It's a node positive disease, T2N1 disease. As per the current treatment indications and the current guidelines, she received dual HER2 blockade in the form of neoadjuvant therapy, TCHP. She underwent surgery, did not achieve pathological complete response, and as per the current indications, received TDM1 and adjuvant radiation. After completing her adjuvant treatment, 2 years down the line, she developed cough and backache, for which she got evaluated. Next slide, please. And the evaluation revealed that there are multiple lesions in bones and multiple pulmonary nodules. So at this time point, let me ask my panelists. So a HER2 positive breast cancer patient relapsing after 2 years, and let me begin with Dr. Priya Tiwari. So in your clinical practice, would you want to do a repeat biopsy and check for HER2 status, or shall we start with the treatment upfront?
So I'll
What is your
definitely do a
practice?
rebiopsy, sir.
You'll rebiopsy,
Definitely.
and why do you want to do that? So in addition to proving the disease, any other information we'll
So
get?
you do see gain and loss of receptors.
Right. So Dr. Pankaj Goyal, what is your practice? Do you repeat ER/PR HER2 in all cases of recurrent metastatic breast cancer?
So, had it been something like hormone positive HER negative disease recurring in bone, I would have taken it as a recurrence as a hormone positive disease. But in such patients
Right,
where the patient's status was ERPR even triple negative, I'm comfortable treating them as triple negative if they are recurring in a year or two. But when
right,
we are thinking about ERPR negative HER positive disease and that too recurrence after 2 years, then I concur with Dr. Priya. I want to
right,
go ahead with the repeat batch to see what is the receptor status now. And also
right,
to add on this NGS, I'm not a big fan of NGS in breast.
right,
Dr.
right,
Alok, just one point here. It's well known that sometimes by a HER2 based treatment, it's known that HER2 receptor status might be lost.
right. So, Dr. Tarachand, our panelists are agreeing on the fact that, and they are very right in saying that HER2 is lost in approximately 10 to 12% of patients at the time of relapse. Do you do NGS in your routine clinical practice for metastatic breast cancer, Dr. Tarachand?
No, boss, I am not doing routinely NGS in at least
Right,
breast cancer patients on regular basis because
right,
we are comfortable with mainly the IHC4
right,
only.
right,
And as per if we see that there are no high mutations seen in the breast cancer, even we can see that the immunotherapy now just approved in only triple negative breast cancer because there is less mutation burden in breast cancer patients. So that's why
right,
I usually don't recommend NGS in breast cancer.
right. Thank you. Can we move on to the next slide, please? Yeah, next slide. Yes. So, a patient relapsing after 2 years, and let me ask Dr. Satish Sharma. So, we did a biopsy. It was proven to be a HER2 positive, hormone receptor negative disease, and we have so many options available. So, amongst these options, what would you select? Dr. Sharma. If Dr. Sharma is not there, maybe Dr. Chandru, can you take this question? A dual HER2 blockade with taxane or a single HER2 blockade or a TDM1 in
The
this setting?
evidence, Alok, for the as for the evidence with as per the Cleopatra, I would go with the dual anti-HER2 with the taxane.
Right, right. And
Yeah.
I believe all the panelists would agree that in the first line metastatic setting, so this would be considered first line metastatic because patient is relapsing after a period of 2 years. Dual HER2 blockade has become the standard, and as Dr. Chandru said, based on the Cleopatra study, the demonstrated overall survival improvement has made it so. So next slide, please. So these are the Cleopatra curves, and the OS at the end of the study, you can see that the delta improvement with dual HER2 blockade is to the tune of 16 to 17 months. And the hazard ratio is also quite remarkable, 0.69. I mean, there is no doubt that dual HER2 blockade has become the standard of care rather than single HER2 blockade for most patients with HER2 positive MBC. Next slide, please. So this patient received taxane plus dual HER2 blockade. After 6 cycles, she had a good response. Paclitaxel was stopped and she continued on trastuzumab plus pertuzumab maintenance. Next slide, please. So let me ask Dr. Arun. So what happened is this patient continued on the maintenance form of dual HER2 blockade. So what do you do, Dr. Arun, in your clinical practice? Once the see most patients, around 80% of those would respond to taxane plus dual HER2 blockade. After completing 6 cycles, do you routinely use dual HER2 maintenance, or is there some other strategy you follow, Dr. Arun?
No. We follow only the pertuzumab trastuzumab blockade, dual blockade as a maintenance. We just to
Right.
hold up the taxane after 6 cycles, then we go with the
Right.
dual blockade.
And for how long would you continue that maintenance?
So usually I discuss with the patient. I will tell them
Right.
till progression, till toxicity, and
Right.
till the next event, I just continue the dual blockade. Sometimes the
Right.
patient depends on the patient tumor status. We can take a
Right.
call.
Right.
But if they are doing well, I'll put on till the next progression, till the financial
Right.
status are good enough to take on this.
Right. And just an extension of this question, in that particular situation, how frequently do you ask for echocardiogram?
So usually it will be every 4 cycles is echocardiogram. But we are fortunate that we have a Muga scan in our institute. So I
Okay.
just go with the 2D echo every 4 cycle, and afterwards, if there is any discrepancy in
Right.
the echo findings, I'll go with the Muga scan. That's it.
Right. So this patient continued on this prescribed treatment for 18 months, and after 18 months, she developed increased cough, for which she got evaluated, and this time the lung metastases have increased. There are new liver nodules as well. So disease progression on first line dual HER2 blockade. So let me ask Dr. Priya. Dr. Priya, next slide, please. So clearly, the patient is now progressing on dual HER2 blockade after 18 months of maintenance. What would be your drug of choice here, given the fact there are so many options?
So now we have excellent data of TDXD in second line
Right.
compared to TDM1, so why not?
So the decision making has become more simplified since the overall survival data has
Yes,
become
and
available.
actually it will be in the real life setting, it will be decided by what the patient can afford. But
Right.
given all the choices, yes, TDXD.
TDXT would be preferred. So had it been December 2023, TDXT was not available. So what would you then prefer before
That's-
that?
So I'm not sure if pertuzumab on progression or trastuzumab, pertuzumab, continuing pertuzumab will actually, I don't think so, will help. So
Right.
the only thing is TDM1 has always been the standard of care in second line setting. But I am not sure
Right.
if the patient has received in adjuvant setting, but I think it's a really long gap from the adjuvant TDM1 also. So yes, why not
Right.
TDM1? Yes.
Right. So Dr. Pankaj, would you differ? TDXT is a sort of, I would say, knee-jerk reaction now for this particular situation?
The data is very convincing. I should not call a knee-jerk reaction, and we are keen in using this in provided the patient can afford this. So
Right,
I this, we have excellent data, but then if patient is having a lot of lung metastasis, then we'll
right,
have thought about the TDXD having this
right,
toxicity. But
right,
given the situation, I think still this will be having an upper edge over TDM1.
right, right.
So Dr. Alok,
So,
actually, I agree with Dr. Pankaj has actually
mm,
raised a very interesting point
mm,
here that because
mm,
the
mm.
TDXD is known to cause ILDs.
Yeah,
So, yes, would you do a PFT here and
yeah.
then
With heavy heart, we'll still start TD.
decide?
Right. So you see, in fact, in the follow-up data of the TDXD study, the incidence of long-term ILD pneumonitis has actually increased. So
Hmm,
earlier it was reported to be around 10%, 11%. Now it is 15% with the
hmm,
longer follow-up. So clearly, it is one of the important side effects of TDXD. But at the same time, even in patients who have lung metastasis, and that is just my thought process, see, TDXD would give you somewhere around 80% response rates anyhow. So, although we might check for you can do pulmonary function test, but having lung metastasis would not deter you to use TDXD. That is my thought on that. Dr. Tarachand, what is your opinion? Next line of management.
But I will go with the TDXD if the patient's lung functions are not compromised or patient is not
Right,
having already interstitial pneumonitis or any yeah emphysema lung जो है, if he is
right,
not having then if she is not having then I will go with TDXD. And secondly with the TDXD, yes, there is a interstitial lung disease around 10 to 11%, but the thing is the
right,
grade 3 is only 1.3% or anything. So most of the patients were having grade 1 only that can be
hmm,
resolved spontaneously, and most of the patients in grade 2 can respond within 2 weeks of the steroid only. So grade 3 only 1.7% that contraindicate the TDXD.
right. So, but if you look at the trial, you will find that as much as 15 to 18 or maybe around long term 20% patients had to discontinue TDXD because of some toxicity. And predominantly it was the pneumonitis and interstitial lung disease. So, next slide, please.
So, boss, I am not having so much experience, but I am
Right,
using in two patients. They have received the 3 cycles till now, both of them, and still only one patient had the grade 1 vomiting around 3 episode. Sorry, grade 2
right,
vomiting, and only
right,
one patient that was resolved after upgrading the antiemetics to the high risk antiemetics.
right, right,
Otherwise, patients are not having any complaint till now.
right,
Even
right. So,
neutropenia is well documented in the literature that around 25% patients were having neutropenia,
right,
but
right, right.
both of them are
So, so
normal.
Dr. Tarachand also brought out an important point that this is considered to be an emetogenic drug, and we need to use proper anti-MSs, much more anti-MSs as compared to TDM1 when we are using TDXD. And the recommendation of our panelists is largely based on this Destiny Breast 3 trial, which included patients with metastatic HER2-positive breast cancer previously treated with trastuzumab and taxane, randomized to receive TDXD versus TDM1 with progression-free survival as the primary endpoint. Next slide, please. So on the right side, you can see, and this was the interim analysis of this trial at a median follow-up of around 16 months. And this interim data, when it came up, it showed how widely the curves are separated, and the hazard ratio of progression-free survival was 0.28. This was quite remarkable. And in fact, you can see in this the PFS in the TDXD arm, it was not reached. However, now we have an updated analysis from this trial where we are looking at a median follow-up of around 28 months, and this median PFS in the TDXD arm has come out to be around 29 months. So 29 months of PFS in TDXD versus 6.8 months with TDM1. So clearly, it appears to be a superior molecule. Even the response rates are almost 2.5 times, and PFS is several times than TDM1. So next slide, please. And this benefit was there irrespective
Yeah, next slide, please. The next slide. Yeah. So this is the updated overall survival analysis which came last year and which led to this drug becoming a standard of care treatment. So you can see that the hazard ratio for OS is 0.64. So, with a very significant p-value, the response rates are close to 80%, which you get to see in first line setting with when you use dual HER2 blockade with taxane. So this drug is providing similar response rates even in second line setting. And because of this significant improvement in OS, it has become a standard of care. Dr. Chandru, any thoughts on this? The response rates, 16% patients achieving complete response. So
I think
how
that is why this has been regarded as an unprecedented advantage in the second line, and it's become a category one recommendation. No wonder the trials on the first line. So who knows? It can replace the dual anti-HER2 as well.
So just I will
So,
like to share one of my case, sir. This is we have this patient. She was treated on. Hello.
hello. Yes,
Sir, can you hear me?
Dr. Satish.
Yes, sir. Yes. Sir. So I had
Yes,
this
Dr.
just one patient who had CA breast. She was on trastuzumab, pertuzumab. Then she was on adatrastuzumab, and following that, she had progression with brain mets, multiple brain mets, and she was this all cerebral symptoms. So first two cycle, the symptoms went off, and we have done after fifth cycle, they were persistent on doing a PET scan, and this patient is in complete CR. So very wonderful results. Like
Right.
two of my patients, they have went into complete CR after the drug.
Very good, very good. So I mean, sometimes when these patients achieve CR, and Dr. Arun, the next question is to you. Sometimes we wonder for how long shall we continue such therapies when you achieve CR. So for pembrolizumab, there is some data that after 2 years, for most indications, you continue for 2 years. For TDXD, for how long would you want to continue, Dr. Arun?
So I'm not sure, sir, but the thing is, if the patient agrees and the financial director agrees, I will go on till the next event.
But that's the other problem. Just I want to add this one. I was not getting it. This my one patient has she has taken till 7 cycles. 7 cycles she has taken 2 days back. What she used to get, she is not getting ILD. We are doing PFT. We are doing HRCT test also. But what she thinks she is getting recurrent pneumonitis.
Right.
And that we are not figuring out, but probably because of the weather. But this one patient who had this
recurrent pneumonitis is also, pneumonitis is a known complication or known adverse effect of TDXD. And it is very much there and one of the most common reason for withholding this treatment, in fact. So next slide, please. Let me just quickly complete this case. So this patient at that point in time, February 2022, received TDM1 and not TDXD. Next slide, please. And after 7 months, she had progression in brain, which she received SRS to brain. Next slide, please. And this point brings us to an important aspect in the management of HER2 positive breast cancer, which is management of brain metastasis. So since these patients are living longer and longer with subsequent therapies, most of these patients would end up developing brain metastasis. So I'll start with Dr. Priya again. So asymptomatic HER2 positive breast cancer, in asymptomatic disease, do you recommend doing whole brain radiation, or now systemic therapy is the preferred option?
Sir, asymptomatic brain mets, I would not prefer to treat them using WBRT.
Right. So and the reason behind saying that is probably the fact that we have got much better responses, intracranial responses with the currently available drugs, especially TDXD. Am I right?
Yes, sir. Yes, sir. And if there are symptomatic lesions, then you can do like you have SRS, you have surgery. You
Yes,
can again document sometimes the intracranial status of HER2 receptor also changes, sir.
right,
All those
right.
options are there for, but I'll reserve it for the symptomatic patients. And with these newer drugs, like you just told about the tucatinib and TDXD, they have good brain penetration. So I agree. Why not try them in a
Right.
asymptomatic patient? Yes.
Right. Dr. Pankaj, radiation for asymptomatic
So,
brain
so
metastasis or the
apart from
systemic
whatever,
therapy?
Dr. Priya has just told, I agree with most of the points. But in specific few conditions, I might still go for radiation. Like, for example, if the patient is say on TDM1, patients getting it free of cost now. Next to catanib TDXD is not there available with us. So next
Right.
option will be going to either lepetanib capecitabine or something. So if we are having a
Right.
good control, systemic control over say TDM1 and I'm getting free of cost, maybe for financial issues, when I'm not getting the costlier drugs, I might go for radiation and continue the same TDM1. So people may
Right.
differ, but that is the
No,
thing
so
which
I
I
think that's a
occasionally
fair,
do.
yeah, that's a fair point, Dr. Pankaj. I mean, I completely agree, and we all have done that in
Yeah,
oligometastatic diseases. And
yeah.
in most such cases, what we have found is after 5 months or 6 months, the patient has then progressed. But it gives 5 months, 6 months time
So
to the
so that is
patient.
what reserve
Uh,
the drugs for the later lines,
right.
later times.
No, fair, that's a very fair point. Very
Yeah.
fair. Dr. Tarachand, management of brain metastasis in HER2 positive breast cancer. Your take on that, radiation or systemic treatment first?
Because if the patient is symptomatic, then we need to control immediately. What I think that will be the
Asymptomatic.
asymptomatic, then we can go with the red mark, which you have done red square. No? That is a
Right,
good advice.
right,
Paper
right.
is
Next
out. No?
slide, please. Next slide, please. So I believe most of our panelists agree that TDXD has significant intracranial response rates. From Destiny 03, it has been mentioned around 66%, which is good. Next slide, please. And next slide, please. Yeah, and then there have been other studies which have looked into intracranial responses. Even in patients who have received radiation in the past and then progressed, the response rates with TDXT have ranged around 55%, so which is reasonably good. Next slide. So at this time, the patient received TDXD as per the current recommendation. Next slide, please. So coming to the last part of this discussion, which is regarding toxicity. So Dr. Satish, uh,
Yes.
so what anti-MSS do you usually use when you administer TDXT? What drugs are you using?
So I'm using sir post-aprepitant, and sir, in three of my patients I'm giving, I'm not finding it very highly hematogenic. Like I'm giving
Right,
post-aprepitant, then our
right,
Dexa, then
right,
Rantac, and this on
right,
discharge I'm giving olanzapine because most
right,
of all three patients are this brain mets. So of course,
right.
and I
So doc,
didn't.
right, right.
सर
Dr.
इतनी
Chandru,
सर इतनी
it,
इतनी महंगी दवाई है, एक केंजियो बनता है सर.
Dr. Chandru,
May I? Huh?
Dr. Chandru, what do you say? So the general recommendation is to use a triplet
Yeah,
antiemetic.
highly emetogenic regimen. So that's what
Yes.
I'm
So
So
following.
actually, when it
have
was
you
launched, it was actually, I think, labeled as moderately hematogenic, but later on it has been revised to, I think, highly hematogenic drug.
Yeah.
So actually,
right?
we were part of Destiny 008 trial and we lost our patient because of the MSS, sir. We lost the patient
Oh,
did
Oh
not
my
come for
God.
follow-up. We lost a
scary.
follow-up, that means, because of the
Dr.
MSS.
Chandru, what has your experience been with regards to the lung toxicity? Any
So
experience with lung toxicity?
I have been a part of DB06, so used in one of the patient, and one more patient, two of the patients who do not have the lung toxicity. So one of my colleague in Belgium has
Right,
used it, and the patient developed a lung toxicity grade 4. Now on steroids, she's reversing, I
right,
believe. So two of
right,
my
right.
patients did not have any lung toxicity. Yeah.
So I believe that is a very real situation. In fact, Dr. Satish reported that his patient was developing pneumonitis. I mean, I personally have used this drug in 5 patients so far. Touchwood, not one of them have developed pneumonitis so far, but short duration experience. Dr. Arun, last words to you. What is your take on this toxicity profile, different from TDM1?
Yes, sir. Regarding that lung toxicity, it's a matter of concern, but with proper supportive care, with a proper backup, and regarding the radiological changes or potential symptoms, I just evaluate the patient. Then depends on the grade. I will assess what the protocol I have to follow. Usually the schedule I grade 1. If they are not tolerating a symptoms, I stop. Then I restart. Sometimes if it is grade 2 or
Right.
grade 3, depends on the pulmonology consult and every other workup. Then I will take a call. Usually, the
Right.
most of them
Right.
subside with corticosteroids, but we are lucky enough that
Right.
we didn't face any problem till now.
Right. So I think the message which is going out is that at least two things we should be watchful for. One is MSS and one is lung toxicity. Next slide, please. Yeah, next slide, please. Next slide. Yeah. So I think we have covered all these points, and these are the guidelines, and all the guidelines have put up TDXT as second line treatment. Next slide, please. So with this, I will conclude this session, and I would thank all my panelists for this such an interactive session, such an active participation. We have covered various aspects with regard to the HER2 positive metastatic breast cancer, covering TDXD, brain metastasis, and side effects and side effect management. And thank you, organizers. Thank you, Ved sir, for giving me this opportunity. Back to the organizers. Thank you.
Thank you, Dr. Alok sir, and all the esteemed faculties for such an informative panel discussion. And for further proceeding, I would like to invite the second chairperson, which is Dr. Kaushal Kalra sir, who is a consultant medical oncologist, VMMC and Safdarjung Hospital, New Delhi.
Good evening, all. Thank you, organizer, for giving me this opportunity. So next session is the speaker session, the current therapeutic landscape of HER2-low breast cancer. And the speaker is Dr. Paolo Tarantino. He is a breast medical oncologist and clinical researcher. He is currently pursuing an advanced research fellowship at Dana-Farber Cancer Institute and at Harvard Medical School, Boston, and a PhD in clinical research at the University of Milan. His research focuses on the study of HER2 oncoprotein, the biology of HER2 low breast tumors, and the development of novel antibody drug conjugates. So I would like to welcome Dr. Paolo Tarantino. Dr. Paolo, please.
Namaste. Hello, everyone. It's a real pleasure to join you all to kind of bring this discussion forward. We've been hearing about HER2 positive, and now we're starting to think and talk about this new subtype of HER2 low. That is something very new. I think all of us are kind of learning along the way how to think of this type of breast cancer, how to treat it. And so I would love to go over a few slides and then maybe also have a little discussion on this new entity. And I'm gonna start sharing slides. I'm not sure if I'm allowed to share my slides or if I just need to say
Sir, it is
next.
perfectly fine if you want to share your slides, sir. You can
I
share
think it
from
would
your
be
end.
best. If possible, I think it would be best. All right. So, now I'll talk of the current therapeutic landscape, the landscape of HER2 low breast cancers, and basically going to the basics of what is HER2 low breast cancer. We need to remember that about 80 to 85% of the breast cancers that we find in the clinic are HER2 negative, meaning they don't have the overexpression or amplification of HER2. And so we have been calling them HER2 negative for a long time, and we've been treating them according to the hormone receptor expression. If they were hormone receptor positive, treating them as luminal breast cancers. They're the most frequent, actually. And we know that in the metastatic setting, we can use endocrine treatment, several biologic treatments. And in triple negative breast cancer, instead, we mostly use chemotherapy with few recent advancements. But both require palliative treatment. And the way we usually treat patients with hormone receptor positive HER2 negative breast cancer is that we try to start first with endocrine treatment. And once again, biologic treatments like CDK4/6 inhibitors first, and then you can also consider other treatments like everolimus or more recently elacestrant capivasertib after that. But the idea is that we try to first exhaust the endocrine sensitivity of the tumor before moving on to chemotherapy strategies. And usually once we move to chemotherapy strategies, we think of utilizing sequential lines of single agent chemotherapy. And in terms of chemotherapy, the latest chemotherapy to be approved is eribulin. Eribulin was approved based on the Embrace phase 3 trial, based on a response rate of 12% and PFS of 3.7 months. This was a trial that enrolled highly pretreated patients, but I think it tells us that the bar is low. And we realize it in the clinic when we treat patients that are highly pretreated, either with hormone receptor positive or triple negative disease. The activity we can achieve is really not outstanding. Usually, the maximum we get is some stability or some shrinkage. We clearly need better treatments. The same, of course, for triple negative breast cancer, for which overall survival in the metastatic setting is usually 2 years or less, even with immunotherapy or with sacituzumab. And so we definitely need something more for these patients. And something more is coming and has come recently. So once again, HER2 negative breast cancer, HER2 positive breast cancer. For HER2 positive, we know that we have 8 anti-HER2 agents that are approved by the FDA, for instance, for treating HER2 positive breast cancer. These are a minority of the patients, but for these, we can utilize trastuzumab, pertuzumab, lapatinib, T-DM1, T-DXd. I'm not sure if all of these are available in India, but I hope that the key ones, at least, such as trastuzumab, that really can have a major impact, but also trastuzumab deruxtecan are approved and available. And I noticed that trastuzumab deruxtecan was approved, for instance, in India. But I think it's important to realize that also the ones that we call HER2 negative have some HER2 expression. If you do immunohistochemistry, most of the patients that we call having HER2 negative breast cancers have tumors that actually have immunohistochemistry score 1+ or 2+ ish negative for HER2, with up to 1 million HER2 receptors on the cell membranes. Could these patients benefit from HER2 blockade? Well, not from trastuzumab. There was a large phase 3 trial that tested if in patients with high risk HER2 low early breast cancer, adding trastuzumab to traditional chemotherapy was beneficial. And after enrolling more than 3,000 patients, the answer was clear: no benefit from adding adjuvant trastuzumab in HER2 low patients. So trastuzumab is a life-changing drug for HER2 positive breast cancer, but blocking HER2 with trastuzumab really doesn't work in HER2 low. You need HER2 overexpression or amplification in order to have benefit from HER2. But then something happened. We started developing novel drugs for HER2, and probably the key drugs that have changed this paradigm are antibody drug conjugates. And basically, all of the antibody drug conjugates that are approved have got the same schema, meaning that there is an antibody that binds to a tumor-associated antigen. And in the case of T-DM1 and T-DXd, the antibody is trastuzumab. This is linked through a molecular linker to a chemotherapy payload. And it's very important. Both parts are very important because the chemotherapy payload determines the activity and sometimes also the types of toxicities, as you see. And the linker determines how much the payload can diffuse, where the payload detaches from the antibody. And so it's extremely important for the pharmacokinetics. And T-DXd really allowed to see the first activity in HER2 low because of some features. 2 important features are that there is a cleavable linker, and which allows the payload to diffuse very easily and very well outside of the cell, even after internalization. And the payload is a highly potent topoisomerase inhibitor that is somewhat lipophilic, and so it allows it to be, once again, to penetrate tumor membranes and have broad activity even in HER2 heterogeneous tumors. And then it has a high drug to antibody ratio, 8 molecules of payload for each antibody. And so the first activity that was seen in HER2 low, that still was not a category back then in 2018, was in the phase 1 trial, the J101 phase 1 trial of T-DXd, in which in 54 patients with highly pretreated metastatic breast cancer, basically the same population than EMBRACE, patients received T-DXd and they got a response rate of 37% with a median PFS of 11 months, almost 1 year. So see how this compares to eribulin. There is really no comparison. And also the waterfall plot was extremely exciting back then, justifying further testing in larger trials. And also justifying the idea that actually we may think of broadening the targetability over HER2. Back then in 2018, 2020, we only had this small piece of the pie of HER2 positive, 15%, but then all of the other patients did not have any targeted treatment for HER2 that were available or that has shown to be active. But after seeing the data with T-DXd and then also data with other ADCs like trastuzumab rocarzine, disitamab vedotin, several others, basically it was becoming clear that even in HER2 low breast cancer, we could expand the targetability of HER2. And one thing that is important to remember is that HER2 low expression, so 1+ or 2+ish negative, is strongly linked with estrogen receptor expression. And so if you have no estrogen receptor expression, what we call triple negative breast cancer, we can expect approximately 40% of the tumors to be HER2 low. But the higher you go, the higher you see there is the chances of finding HER2 low expression. And so more than 60% of ER high tumors are HER2 low. So the higher the estrogen receptor expression, the higher the likelihood of finding HER2 low expression. And the trial I mentioned that confirmed the paradigm of T-DXd in a larger trial was Destiny Breast-04. We all might have seen this presentation probably several times. And I always, whenever I see it, I find it very, very impactful. And I remember the moment I was in the room at ASCO 22 when it was presenting. It was very emotional and very important, I believe. And why is that? Because this trial, for the first time, tested in a phase 3 trial, an NTR2 ADC versus traditional chemotherapy for patients with HER2 low metastatic breast cancer that have been pretreated with endocrine treatment and 1 to 2 lines of prior chemotherapy. Primary endpoint being progression-free survival. Most of the patients had hormone receptor positive disease, but there were approximately 10% that had triple negative disease, patients that received 1 median line of prior chemotherapy. Most of the patients with ER-positive disease received CDK4/6 inhibitor. So a modern cohort of patients. In this modern cohort of patients, at the latest update of the data, T-DXd more than doubled progression-free survival. With chemotherapy, we basically saw what we saw with the eribulin in EMBRACE, about 4 months of PFS. With T-DXd, that PFS approached 10 months. It was 9.6 months, significantly improved over chemotherapy. And this was both among hormone receptor positive metastatic breast cancer patients, but also in the overall cohort when you add the triple negative. Overall survival was also improved by more than 6 months in this cohort. It was statistically significant since the first presentation of the data. And you can see that the curves diverge very early, suggesting a clear benefit since the beginning for these patients. And also in patients with triple negative breast cancer, there was this exploratory analysis showing a benefit in progression-free survival and overall survival. Pretty striking. And this basically, and then if you look at response rate, I think also is striking. Usually we think of PFS and OS, so survival data, to be more easily understandable in the clinic. But actually here, I think my takeaway from the response rate is that half of the patients or more that receive T-DXd for HER2 low disease are expected to have a response, meaning a shrinkage more than 30%. But actually, if you look at progressive disease, much less patients are expected to progress through T-DXd, less than 10%. Whereas with chemotherapy, more than 20% of the patients are expected to progress through chemotherapy. So in general, patients receiving T-DXd have got more than 50% chance of achieving a response and very low percentage of patients progress to treatment, which also is very important in this setting. What about side effects? I think in the beginning, we were probably not expecting to see some of the chemotherapy-related side effects that was seen with TDXD. And instead, I heard the discussions, and they were very appropriate about the fact that we need prophylactic treatment for nausea, because in this agent has been in time kind of upgraded and downgraded between moderate and highly emetogenic, but it's clearly emetogenic. And so it's important to manage nausea and vomiting. We don't want to lose patients on follow-up in the trial and not also in the clinic. And so we want to manage nausea and vomiting the best possible way. Usually what I do is with 3 drugs regimens with the potential addition of olanzapine if needed. And other side effects that are commonly seen with TDXD are fatigue, of course, which is harder to manage. And usually it's managed with dose reductions and a few other tricks that we have in oncology. But probably one very important one is interstitial lung disease. And we will talk about that. In this trial, there was approximately 1% of the patients that had fatal ILD, with approximately 12% having any grade ILD. And I think this rate of fatal ILD is decreasing in time as we are learning to manage it better, but it's still there. So it's important to remember about this side effect. Whereas cardiotoxicity is uncommon. It's basically similar to trastuzumab for what we see, meaning that about 5% of the patients are expected to have some decrease in left ventricle ejection fraction. And we know that this is temporary. If we interrupt the drug, usually there's a recovery in this side effect. So this was the trial that back in 2022 really changed practice and changed also our idea of targeting HER2, not only in HER2 positive, but also in this wide percentage, more than 50% of the patients with HER2 low metastatic breast cancer, and led to the approval by the FDA and also the EMA. When we looked at the data among our patients at Dana-Farber in Boston that we treated with TDXD in the last few years, we had 200 patients in this course. There were also some patients from Duke, another center. And we found that, of course, patients with HER2 positive metastatic breast cancer had the longest activity. Patients with HER2 low at average activity. There was approximately a 4-month PFS, that time to next treatment for patients with HER2 zero disease, which I think is intriguing. You can see some activity even in the absence of HER2 expression on the membrane. And I think we need to characterize this better. And there are some ongoing efforts to look at TDXD also in HER2 zero. And then we found that, and we will discuss about this, because we know that HER2 is a dynamic biomarker, and we found the best activity among patients with stable HER2 low expression in time, although, once again, some interesting activity also in patients with changes in HER2 from zero to low or the opposite, and we will discuss about that. Then we looked at some biomarkers. There was, let's say, a suggestion that there may be lower activity in patients with ERB2 hemizygous deletion, so a deletion of one of the alleles, but this was not statistically significant. And then we conducted this liquid biopsy assay looking at HER2 addition signature, and it seems to track very well with the activity of TDXD, but it's still preliminary. In the post-TDXD setting, we found approximately 3 to 4 months PFS, time to next treatment, with post-TDXD regimens, which kind of tell us that we need to develop better regimens here. And in terms of toxicities, we were glad to see that there was no grade 5 ILD. Actually, there was 1/3 of the patient that had dose reduction for toxicity, which is pretty common. It's something that we see pretty commonly and usually works to decrease the toxicity. But also about 15% of the patient discontinue treatment, often for ILD, usually asymptomatic or symptomatic ILD, but low grade, and very few cases of cardiotoxicity. Beyond HER2, I think all the experience with targeting HER2 with ADCs also led to more confidence in targeting other antigens, such as TROP2. And TROP2, we know that is expressed by about 90% of breast cancers and highly overexpressed by approximately 40 to 50%. And we know that we have an ADC that targets TROP2 and delivers a topoisomerase inhibitors, just like TDXD. The payload is slightly different. It's SN38, that is the active metabolite of irinotecan. The drug to antibody ratio is very similar, approximately 8 molecules of chemotherapy per each antibody. The linker is slightly different. It's more unstable, it's acid label, and so in acidic environment, you have release of the payload, and usually the half-life of this drug is approximately 16 hours, less than 1 day, whereas for TDXT, it's about 5 days. So you have a continuous release for more days with TDXT. That said, sacituzumab govitecan was first at an accelerated approval based on the phase 1 data in triple-negative breast cancer, showing that in patients with highly pretreated metastatic triple-negative breast cancer, you had more than 30% response rate, which was very promising and was further confirmed in the ASCENT trial that randomized patients with highly pretreated metastatic triple-negative breast cancer to sacituzumab or traditional chemotherapy. Recently, there was the update published on JCO showing very similar data from this. I'm showing about 5 months of PFS with sacituzumab versus less than 2 months with chemotherapy. Overall survival almost doubled with sacituzumab govitecan over chemotherapy. Very important data that led to the regular approval of SACI in metastatic triple-negative breast cancer, and also to the opening of a second trial, the TROPiCS-02 trial for hormone receptor-positive metastatic breast cancer. Similar design, patients in this case had hormone receptor-positive HER2-negative metastatic breast cancer had been pretreated with endocrine treatment, CDK4/6 inhibitors, at least 2, but no more than 4 lines of chemotherapy, randomized to sacituzumab or chemotherapy of physician choice. This was a more highly pretreated population than DESTINY-04. Instead of 1 line, in this case, they had 3 lines of median prior treatments, and PFS in this case was improved from 4 to 5.5 months. So numerically a smaller benefit, but still there was a significant benefit in overall survival. 3.3 months in overall survival benefit that was statistically significant. And that led to the approval of sacituzumab by the FDA, also for patients with hormone receptor-positive metastatic breast cancer. In terms of side effects, pretty similar actually to what we see with irinotecan. And so we see alopecia, we see neutropenia, fatigue, and really the key side effects we see with sacituzumab are neutropenia, which often requires growth factors, and also nausea, vomiting, and diarrhea, especially as we see with irinotecan. And I would say it is sometimes a tough drug, but also we're learning how to manage it better. So how to sequence these 2 ADCs with all the other treatment? As I mentioned, in hormone receptor-positive breast cancer, usually I tend to exhaust endocrine treatment strategies, and sometimes it's only 1 line with CDK4/6 inhibitors. Some other times it's 2 or 3 lines. It depends on the genomic profile, on the type of patients. But usually after exhaustion of endocrine treatment strategies, I move on to chemotherapy. If I'm allowed, I try capecitabine, that usually is a good link between endocrine treatment and other infusive strategies. But once the tumor is endocrine refractory and chemo refractory, the best treatment we have is TDXT, if there is at least 1 biopsy that is HER2 low. And after TDXT, we can still consider sacituzumab or further chemotherapy. Whereas for patients with triple-negative breast cancer, if you have HER2 low expression, usually still we start with chemotherapy, with or without immunotherapy, depending on PD-L1 status. But then the best second-line treatment is TDXT or sacituzumab. It's still very hard to decide, meaning that there is good data in support of both. And I think if both are available, it's good to discuss with the patient the pros and cons of both options. Whereas for patients with HER2-0 disease, for the moment, we only have sacituzumab available. So I mentioned interstitial lung disease. How to best monitor and manage interstitial lung disease? Recently, Dr. Tolani and I suggested these 5S rules that are kind of a way to memorize some of the key steps to monitor and manage ILD. The first one is screen, meaning understanding what patient you have in front of you, what are the baseline comorbidities. And in some patients, for instance, that have COPD or other comorbidities and extensive lung disease where you expect to have less pulmonary function, you may consider reducing the dose up front. It's not something that is yet recommended by the guidelines, but I think in clinical practice, in certain cases, it may be warranted. But in general, screening is also important to understand how to tailor the scanning. And in terms of scans, we tend to perform CT scans of the chest every 6 to 12 months to monitor for ILD. 6 is quite tight, and we tend to do it if we have concerns about the patient's frailty, for instance. 9 weeks, I think, is more feasible, and 12 weeks is not unreasonable, but I would not go beyond 12 weeks. Synergy basically means multidisciplinary management, and knowing that reviewing the scans with radiology can be helpful, discussing a case of suspected ILD with pulmonology can be helpful, of course, coordinating with the nurses is extremely important. So synergy with all the care team. Suspending treatment may be the single most important thing to do, because many of the first ILDs that we've seen with TDXT were because TDXT was continued through some cases of ILD. And so we need to stop TDXT whenever ILD is suspected. And finally, steroids is the main treatment that we have. The dose needs to be adapted to the grade of the side effect, but it's important to always remember to start steroids. I start even in grade 1 cases, just if we have radiologic evidence, starting steroids, the 5 S's. Nausea and vomit, I mentioned it, and I agree with what I've heard also from the panel previously, that usually having a 2 to 3 drug regimen at least is a good idea, including dexamethasone, a serotonin antagonist, and an NK1 receptor blocker, and also sometimes adding olanzapine may be helpful. And then I mentioned also the evolution of HER2. We know that some tumors have HER2 low status that can change in time. It can be, for instance, HER2 0 on the primary tumor that becomes HER2 low, or the opposite way around. And I think it's important to remember this, and important to remember that so you can have patients with heterogeneous results, with a primary tumor that is low, that becomes 0, and then is still 0 at another biopsy, but then becomes low again, and then is 0. And we have to have a rule to define this tumor, HER2 low or HER2 0. And basically the rule comes from the data we've seen, the subgroup analysis from Destiny Breast-04, where we saw that if HER2 low in the trial was defined based on a primary tumor or on a metastasis, you had the same benefit from TDXT compared to chemotherapy, and halving in the risk of progression with TDXT. And so irrespective of the sample type, also archival tissue, newly obtained tissue, there was a similar benefit from TDXT. And so what we recommended in the guidelines, as we will see, is to utilize any biopsy in the history of the patient to consider the patient HER2 low, but it's important to always report the IHC score. And so since the availability of TDXT for HER2 low, we cannot write anymore just HER2 negative. If a tumor does not have the amplification overexpression, we always have to specify in all the notes the IHC score, because this can make the difference for the treatment of the patients. And so once again, in this guideline, that I hope are helpful, because try to address some of the key controversies in your HER2 low field. We kind of recommend them to be broad and to consider any tumor to be HER2 low if there is at least one biopsy, one tumor, one part of the tumor that has been found to be HER2 low in the past. And of course, this will be refined in the future with more data, but I think for the moment it's the best way to ensure that our patients get the opportunity to receive a life-extending drug like TDXT if it's available. In conclusion, about half of all breast cancer can be considered HER2 low, which just tells us how impactful this definition can be on our patients. And DB04, Destiny Breast-04, established TDXT as a new standard of care for patients with pretreated metastatic HER2 low breast cancer, irrespective of hormone receptor expression, both hormone receptor positive and triple negative. And usually we tend to use it after first-line chemotherapy, although it can be also used for patients with fast progression on adjuvant chemotherapy. HER2 low expression on any specimen, primary tumor or metastasis, should be considered adequate to offer TDXT. And if there was never a HER2 low value, we tend to do another biopsy, if this is possible, if it's safe. It's also important with the expansion on the use of TDXT for patients with HER2 positive and HER2 low, and maybe in the future ultra low breast cancer. It's important that we expand the awareness on toxicities, and it's important to discuss that, and also on biomarkers. I think we will need better biomarkers compared to immunohistochemistry. For the moment, immunohistochemistry is what we have, but there is a lot of advancement in the field, and I'm very excited to see what's coming in the next few months. For instance, at ASCO 2024, there will be important data already that will be presented. With this, I would like to thank you all for the attention. here you have email and Twitter, now called X, if you have any question after the session. But I think we have some time now for discussion, and I would love to have some discussion with the other panelists. Thank you so much.
Thank you, Dr. Paulo. Your presentation on the treatment of breast cancer was HER2-low breast cancer was truly commendable. Your expertise and clear communication provide valuable insights. Thank you for sharing such important information. Now, I will ask panelists for the discussion. If any question.
Hi, I'm Dr. Chandagada here. So I just want to ask one question, Prof. So somebody who developed a lung toxicity with TDXT, do you have any evidence of using a TKI along with the steroids so that this ILD can be reduced?
Can I ask what kind of TKIs you were thinking about? Are you thinking of HER2 positive disease?
We're talking about any TKI like Nindatinib, which has reduced ILD in COVID, and for that matter, the O3, the VNAT, that is Imatinib, which has reduced the ILD. So that kind of TKI.
That's a very interesting point. I cannot say I've ever done this, and I don't even know about data in breast oncology with this practice. But I would just say that we really need to study strategies to prevent and to improve ILD, because it's one of the key problems that we have, that about 10 to 15% of the patients have to stop ILD, stop TDXT because of ILD. And so it's a very interesting idea, and I think it should be tested, but I'm not aware of any data in breast oncology. Thank you for raising this point.
Yeah, Dr. Paulo, Dr. Jyoti here. Yes. So one question. So in a known case of interstitial lung disease.
Hello, Dr. Jyoti.
Yeah. So a lady who has been treated for interstitial lung disease and has been quiet, the ILD has been quiet off treatment for say 3 to 4 years, and she has failed multiple lines of treatment. She is now found to be HER2 low. Can TDXT be given to such a patient who has no more an active interstitial lung disease?
So sorry, I lost connection for a few seconds. Could you repeat the case from the beginning, if possible? Sorry about that.
The lady was found to have interstitial lung disease about 4 years ago. She has been on treatment for metastatic breast cancer. She has now failed 3 lines of treatment, has been found to be HER2 low. In view of prior history of interstitial lung disease, would you dare to give her TDXT if the ILD is totally under control? She's off all medicines for many years, and she's maintaining normal saturation, PS1.
This is a great question, because this kind of patients were actually excluded and are still excluded by most trials of TDXT, because one of the exclusion criteria is prior evidence of significant ILD that requires steroids. And so probably this patient would have not qualified for the studies. But in oncology, it's always a matter of balancing risks and benefits. And here we're talking of a patient that probably has got a shorter expected overall survival because it's failed already 3 treatments, and you really need something that works here. And so I think the benefit of what you can have from TDXT is more than the potential risk. We know that there is potentially more risk of ILD if a patient had prior ILD, trying to extrapolate from other drugs. And so I would be cautious. This is one of those patients, for instance, where I would try, if possible, to scan every 6 weeks. But in general, I would absolutely consider it. And I have considered in the past TDXT for patients with prior ILD if it was completely resolved. We don't have yet great data because they were excluded from the trials, but I would consider it just because the drug is so effective that you really don't want the patient to lose this opportunity to get the drug.
Right. Thank you.
Thank you, sir. For all the audience, if is there any other question, just ask right now. Okay. So for further proceeding, I would like to invite Dr. Syed MR Sir, who is the Associate Director Molecular Pathology and ISC from Medgenome Labs Limited for the third session, which is on evolving paradigm of HER2 testing in breast cancer. Dr. Syed Sir, over to you, sir.
Good evening, one and all. I'll just be sharing the screen. Is it visible?
Yes, sir, it is visible.
Okay. Good evening, one and all. I thank at the outset the organizers for inviting me for this session to discuss on the evolving paradigm of HER2 testing in breast cancer. As we all know, breast cancer is the most common cancer and the second leading cause of death among all cancers in women. So biomarker testing, especially the hormonal receptors and HER2 testing, which is done mainly on the primary breast for cancer diagnosis. And even in a metastatic setting, biomarkers should be reassessed at least once to inform treatment decisions. And breast cancer, though it is a heterogeneous disease, so molecular classification of breast cancers into luminal A, where ERPR is positive with having a HER2 negative status, with having a best prognosis. Luminal B, ERPR positive with HER2 plus or minus with a better prognosis. HER2 enriched, which is has a moderate prognosis, whereas another group called the basal or the triple negative breast cancer, which has the poor prognosis. So the treatment selection also is guided mainly by clinical stage, histopathological features, and biomarker profiling, which aids in treatment selection, especially for anti-HER2 monoclonal antibodies or tyrosine kinase inhibitors, or the of late antibody drug conjugates like trastuzumab deruxtecan. So coming to the role of HER2 in breast cancer, HER2 signaling begins with usually with a ligand binding and triggers multiple downstream pathways. Thus, HER2 amplification or overexpression Hello.
Hello, sir.
Hello, is it audible?
Sir, your voice is breaking in between. Your presentation is
visible,
but your voice is like sometimes. I think you have to come in your greater connectivity area. Yeah, sir, go ahead.
Yeah. No, okay. Now is it audible, right?
Yeah.
Yes. Extremely sorry for the internet connectivity. HER2 testing has slowly evolved to improve identification of HER2 positive breast cancer. So this is just a landscape showing the detection of HER2 and approval of the drug trastuzumab in 2000 as a companion diagnostic approval, then which led to the first guideline from the ASCO CAP in 2007, which mainly addressed the concern of high false positivity rate, where IHC 3+ was defined as more than 30% of tumor cells positivity Then later on in 2013, ASCO-CAP guideline updated addressed the concerns about false negatives and introduced the new-ish groups. Here, HER2-IHC 3+ was considered as more than 10% of tumor cell staining. Then in focused update, which came up in 2018, which the guidelines mainly clarified the ISH equivocal results, and there was no further classification or of specific to IHC staining in the 2018 guidelines. Then of late in 2023, recent guideline update which has come up, which affirmed the 2018 ASCO-CAP recommendations and has laid down some best practices recommendations for the pathologists for reporting.
Sir,
And hello?
Sir, make it full screen.
Yes, sorry. Yeah. The impetus for revisiting was the 2022 publication of the Destiny Breast-04 trial, which was published in the New England Journal of Medicine. The ASCO-CAP guidelines periodically evaluates emerging clinical evidence and evolving diagnostic needs to update and improve standardization of HER2 testing and get consistent results in the invasive breast cancer settings. So here HER2 IHC HER2 status is clinically classified as a complete positive with IHC 3+ or 2+ with ISH positivity, or a negative IHC 2+ bar ISH negative, or IHC 1+ or IHC 0. So this is the binary classification of reporting HER2. So the cutoffs were 10% in the 2018 class. Hello.
Yes, sir, you can make it full screen.
Sorry. Then in the 2018, we had the FISH criteria for classifying HER2. Basically, was divided into mainly 5 groups. Group 1 and Group 3 were positive, and Group 2, Group 4, and Group 5 with HER2 sub-17 ratio less than 2 were considered as negative. So trastuzumab deruxtecan, which was to be given in previously treated HER2 low breast cancer. So this led to the results of the Destiny Breast-04 trial. The main criteria where the reduction in risk of disease progression or death by 50% and reduction in risk of death by 36% was shown by this trial. And the main salient features about this trial were the central HER2 testing of orchoid tumor or recent biopsies were taken. Ventana HER2 IHC, which was a 4B5 antibody, was used, and HER2 low definition was IHC 1+ or IHC 2+ without gene amplification. Then this publication of this paper resulted in an immediate clinical need to reliably identify HER2 low breast cancers. So this I'll be showing the new paradigm in the reporting of HER2 in contrast to the binary classification which we pathologists were practicing earlier. HER2 negative where HER2 and HER2 positive. So in the new paradigm, the HER2 negative group includes HER2 score 0 and HER2 score 0 1+, as well as HER2 2+, which is ISH negative. The group is now called as the HER2 low, and the HER2 positivity included as same as HER2 3+ as well as 2+, which was confirmed by ISH as positive. So a total of around HER2 low levels of HER2 expression, it is the incidence is around 50 to 60% when compared to the entire spectrum of HER2 staining. So the main characteristics of HER2 low tumors are these are a heterogeneous group which lack unique molecular and clinical pathological features, and it does not represent a distinct biologic entity and a specific therapeutic subgroup that is clinically significant due to its drug eligibility. And some of the problems while diagnosing which are faced by the pathologists are the HER2 IHC assays are developed mainly to detect HER2 score 3+ breast cancers, but this insufficient dynamic range of reliably distinguish between HER2 0 and 1+ cases, and they were not meant to be used for this purpose based on the previous guidelines. And this has very poor inter-observer variability between HER2 0 and HER2 1+. And many labs which do not use Ventana platform and 4B5 antibody, which was used in the Destiny Breast 04 trial, and sensitivity of identifying HER2 1+ varies among different assays. HERCEP test from DACO has more sensitivity than 4B5, and the pre-analytical factors are likely of clinical importance. And the additional recommendations which are highlighted in the 2023 ASCO-CAP guidelines are the focusing mainly on the pre-analytical conditions, like pay careful attention to pre-analytical conditions and follow the guidelines for optimal tissue handling requirements, and very specifically highlighted about the use of controls with a range of HER2 expression, including HER2 1+ staining, and examine HER2 at 40x magnification. And one more thing was introduced was the consensus scoring, where we need to consult our second pathologist review when, especially in cases of borderline cases where it is difficult to differentiate between HER2 0 and 1+. And the additional recommendations were the always report semi-quantitative discrete like HER2 IHC scores, like HER2 negative for protein expression 1+ staining, and include a footnote in the pathology report on potential therapeutic implications, which
Dr. Sayed, sir, can you hear us?
Yes.
Sir, last 2 minutes remaining, sir.
Yeah, I'm finishing up. So, since the ASCO-CAP guidelines of HER2 testing published in 2007, there are significant improvements in the standardization of procedures, resulting in greater consistency and increased concordance between pathologists, mainly focusing on pre-analytical factors, analytical factors, and post-analytical factors. And analytical standardization mainly focused on cold ischemia time, and which should be less than 1 hour. Standardize the tissue fixation using 10% neutral buffered formalin with 6 to 72 hours, and avoid decalcification when necessary. We need to use EDT as a decalcifying agent. And CAP checklist specifically mentions we need laboratories should monitor cold ischemia type, which should be less than 1 hour and with appropriate fixation time. And second important thing is the one regarding validation. So this talks about the initial validation with 20 negative and 20 positive tests for FDA approved assays. And the controls, as I mentioned, so a range of HER2 expression, including HER2 1+, should be included to have an adequate sensitivity at even at a low range. Magnification at 40x, as pathologists need to be carefully looking at the HER2 staining. And even pathologist training may increase significantly, improve the classification of HER2 0 and HER2 low cases. And HER2 scoring has a subjective component which can be minimized by a number of measures, like seeking consultation with other specialists, then standardizing variables, then participating in PT programs with following the strict guidelines from the ASCO, and computational image analysis may allow robust and consistent quantification in the future. So my last slide, which includes how we are going to report HER2 IHC in 2024. This mainly should include the score, whether it is 0, 1+, 2+. If it is 2+, we should ask for a reflex fish testing, and then 3+. Then percentage of cell staining, 10% cutoff is the with a differentiator factor. Then staining intensity, it should be complete or incomplete, faint, barely perceptible, weak, moderate, or strong. And very specifically, a report should contain the primary antibody clone, specifically the Ventana 4B5, which is FDA approved for under this trial. And the cold ischemia time should be less than 1 hour, fixation time 6 to 72 hours, and consensus, especially when with respect to borderline cases in differentiating 0 with 1 plus, and footnote as per recommendation by 2023 should be included in the report. This is my last slide, mainly telling about the evolving categorization of HER2 with the future prospects. This has been taken from the cancer discovery.
Dr. Sayed, sir?
Hello.
Yeah.
Yes.
Thank you, sir. Thank you for the session. And for the next session, I would like to invite Dr. Jyoti Vadma, ma'am. She is a director of medical oncologist and hemato-oncology, Medanta, the Medicity Hospital, Gurugram, for the case-based panel discussion on HR positive metastatic breast cancer. And ma'am, you can invite your panelists, ma'am.
Okay, so thank you. A bit of correction there. My place of work has changed recently. So let me invite my panelists. First of all, it's my pleasure to have Dr. Paolo Tarantino on panel today for a case discussion relating to hormone receptor positive HER2 low metastatic breast cancer patient. My other panelists are Dr. Ankur Bahel, Dr. Vineet Govind, Dr. Akhil Kapoor, Dr. Rajat, and a pathologist, Dr. Ruchika. I hope we have all of them available. Or is anyone missing?
Ma'am, all available.
Okay, all right. So let's proceed. So the case relates to 2017 when a 50-year-old postmenopausal lady was evaluated and diagnosed with IDC right breast. It was grade 2, both ER, PR positive. HER2 new on IHC was 0. It was clinical T2N0 M0 stage, and she received neoadjuvant chemotherapy followed by BCS and adjuvant endocrine therapy. She was, however, lost to follow-up after the initial start of endocrine therapy. The germline HPOC panel was negative. In 2022, she presented with backache and was found to have bone metastasis. This is the PET CT. You would appreciate pleural-based mass, multiple pleural and pulmonary parenchymal nodules. There was mediastinal lymphadenopathy. There was hepatomegaly with multiple liver lesions, along with lytic skeletal lesions. So a liver biopsy was done. I'm sure you would all agree that a rebiopsy at this stage is indicated, and most of us would agree to do that. Herein, on the biopsy from the liver, it was confirmed to be metastasis from breast cancer. Again, ER and PR positive, strongly positive. HER2 was 1 plus with FISH negative reports. So the Ki67 was 60%. So coming to the panelists, so do you typically rebiopsy a patient in such a or similar setting? Let me start with you, Dr. Ankur.
A bit of correction. Dr. Chandragowda sir will be joining as a panelist, and Dr. Akhil, Ankur sir, and Rajat sir are not available.
Who all is not here? Rajat?
Rajat Govind sir, Dr. Ankur Bail, Dr. Akhil sir.
Okay, right. So,
Dr.
Dr.
Chandragowda sir
Vineet.
is there.
Okay. So, Dr. Vineet, you could start. Would you rebiopsy?
Yes, ma'am. So after, after facing discordance many times, now my practice is to biopsy on every recurrence. So whenever a patient recurs, I always do the biopsy,
So, do you do that irrespective of the interval that has passed by?
irrespective of the interval, ma'am.
Right. Dr. Chandragowda, you agree?
Yeah, ma'am, I agree with Dr. Vineet.
Okay. So, Dr. Paulo, final word from you. Do you rebiopsy at each progression?
So it depends. I wouldn't say each progression. I would say for sure when the patient has metastatic recurrence and whenever HER2 and ER status is helpful. Instead, some other times after progression, we do liquid biopsy if it's available. If ER and HER2 is not critical, you can at least have the genomic profile. But in this case, with the patient just experiencing metastatic recurrence, I think a rebiopsy is a great idea.
Right. So we would agree there. And since we have you here, your opinion about doing NGS in metastatic breast cancer, is that part of your routine practice or do you do it at some later stage?
So it is, and it is also because we have many trials. I feel that in the first line setting, in this case, NGS is not clearly informative, meaning that I would still use the same treatment even if I found a genetic aberration. But if I know that the patient, for instance, it's PIK3CA mutant or with some other alteration, for the second line setting, I already can be prepared to offer a certain treatment or to offer a certain trial. So we tend to do it at metastatic diagnosis on this biopsy. I don't think it is critical to do it so early, but definitely it's critical to do it after the first line because the second line is guided by genomics. And so if possible, we do it already at metastatic diagnosis, but if not possible, I think even doing it later after progression on CDKs is a good idea. What about you? What would you do? Is it a common practice to do NGS either at diagnosis or later?
Yeah, NGS is not a routine for majority of us, but some of us, wherein the patient also agrees and can afford it, we do tend to do it in later stages. So coming to another interesting point, now that we have trastuzumab deruxtecan available, have the panelists started rechecking the earlier blocks for HER2/neu? Because some of them, as we know, with improvements in methodology and with improved awareness, especially also in the pathology circle, are you rechecking, reordering HER2/neu testing on the earlier blocks? Dr. Vineet?
Yeah, so see, if the patient is a potential candidate for HER2, suppose we have a patient where, so in this case, the rebiopsy is HER2 1+. So I don't think getting the old tissue will change anything because if I want to give them an HER2, I can give on this basis.
Right.
But suppose we have a patient where we are out of options and all the prior biopsies are HER2 0. I think last presentation we discussed in a lot of detail that there is a lot of subjective variation in interpretation of HER2. So definitely I would do a check for the old HER2 to see if it might be 1+ instead of 0.
Right. So we always try and look for some sort of targeted therapy, look for targets. So here in HER2 low has become a biomarker, so as to say, isn't it? So we have Dr. Paulo's paper itself, which talks about evolution of low HER2 expression between early and advanced stage. And herein you would note that the HER2 IHC score increased from primary to metastatic tumor in 44% of patients. And HER2, the other way around also it works. HER2 low to HER2 zero evolution also was observed in 22% of patients. So it works bidirectional. And therefore, HER2 low expression is said to be dynamic and may get enriched in advanced stage setting. So it does make sense to look for it.
I have one question to Paul Thornton. I mean, sorry to interrupt. So Dr. Chandragowda here again. So in a patient who has got a metastatic disease, especially in the HER2 low category, initial biopsy was 0. When sometimes we run out of options, would you biopsy all metastatic sites look for some sort of a HER2 positivity so that I can use an HER2 in that particular lady?
It's a great point, and still we don't have a perfect answer, unfortunately. When we looked at the percentage of HER2 low, depending on the organ, there was no organ that had more chances of HER2 low. For instance, we know that PD-L1 is more common in lymph nodes, in the breast, compared to the liver, for instance. For HER2 low, it doesn't seem to be the case. And so usually what I do is just giving it one shot, trying a biopsy of the safest, most accessible biopsy. And if it's HER2 low, offering T-DXd. If it's not HER2 low, I try to look at the other biopsies that the patient received in the past. If there was at least one that was HER2 low, I think it's reasonable to offer T-DXd. But I would not expose the patient to many biopsies just for looking for HER2 low, because it seems a bit too much. And if the disease always was HER2 zero, probably it's a disease that is more basal-like, and probably it's going to be just a HER2 zero disease. But it's very complex, and it's a very great question. Thank you for bringing it up.
Yeah, so coming back to the chances of discordance, we know that this is a real thing which happens. And in the Destiny Breast-04 study itself, if you note here, 78% of samples designated as HER2 low were confirmed as HER2 low. So there was concordance even on central testing. However, 22% of the samples were discordant when checked centrally, even in Destiny Breast-04. So this discordance is very well recognized phenomenon, and one needs to be aware. And now it brings me to a question to the pathologist, Dr. Ruchika Goyal, in our panel. So we know that all these things that are mentioned here, the biopsy type, the sampling, sample handling, the cold ischemia time, we heard Dr. Syed talk about this. So your comments as to, how these different factors influence the result, HER2 result. Dr. Ruchika?
Yeah. Hi, ma'am. So am I audible?
Yes, yes.
Yeah.
Clear.
So, analytical factors do play a very big role in HER2 testing. So pre-analytical, the most important is our cold ischemia time, and our formalin fixation needs to be optimum. So you need to have that 6 to 72 hours, because otherwise what happens is at times you start getting edge artifacts. For example, a core biopsy will show a cluster of cells showing positivity just at one edge, which can falsely be reported as a positive 3+. So optimum fixation is an important factor. Secondly, like Dr. Rahman mentioned in his thing, heterogeneity of you do get clustered or intratumoral heterogeneity. So it is important that when we are analyzing that entire core to be analyzed, and in case a 2+ is going for fish, then it's important that you see the entire core and see where the amplified signals are, because in case you're seeing heterogeneity in a particular area, at least 20 those consecutive signals should be counted to see whether it is actually a true actually a 3+ or not, or whether the fish signals are amplified or not. That is one thing. And the type of assay, yeah, definitely different antibodies show different. Ventana, HER2 4B5 is a good antibody for HER2 testing. That is what we are following, and the results are pretty good with it.
Right. So I'm sure the importance of rigorous HER2 testing has been recognized and accepted by all the pathologists. And how many of you report? Do you rely before reporting just on a single pathology having a look, a pathologist having a look, or do you involve two of you?
So actually, there are no set guidelines that you need to have 2 pathologists, but wherever the case is a borderline case, it is always good if 2 pathologists report that to resolve that ambiguity. And our hospital, we have 2 pathologists doing that. But even if you don't have 2 pathologists, one person is good to report. But in case of a 2+, or where your fish results are following in your group 2 or group 3 category, and you want to be sure that it is a negative, true negative, it's better the second observer comes in. So 2 in case of equivocal cases.
Right, agreed. So you stay on there with us, and even
Yes.
with all that rigorous testing, do you feel there are still some gaps in the current definition of HER2 new IHC reporting? Say 1+ or 0, or between 1+ and 2+. Do you think there's a lot of subjectivity there, and there is an attempt going on to objectify that?
Yes, ma'am. So now with the Destiny 04 trials and a lot of studies going up, and with your new drugs evolving, HER2 low is gaining a lot of importance, and that is essential for a pathologist to report 1+. See, whether you report it out as a HER2 low or not is not the question. The question is you should not be missing those 1+ tumors, and you will not miss those 1+ tumors if you're going to see it under a 40x magnification. If you just dismiss it on a scanner path, there are chances you will miss it because it's already a very faint perceptible kind of staining. So that staining will only be picked up if you spend some time on the tissue and see it on a 40x. So it's important that you report HER2 1+, the low positive ones, either 1+ or HER2 2+, which could be FISH negative. So yes, that is important. And also, I feel HER2 3+ sometimes can be overcalled if you have just a moderate staining. It might be a complete moderate staining, but you don't have that strong intense. So at times, those 2+ could be upgraded as 3+. So when in doubt, always good to take a second opinion.
Right. So fully agreed there. So let's move on. Dr. Chandragoda, do you, so on, say, repeat biopsy, you find it not HER2 low, would you go back to the initial biopsy looking for it? How do you do it? How do you base your decision making?
Definitely, I mean, HER2, as it is evolving, definitely I would like to go back to the old specimen and test it for the HER2 low again, HER2 testing again to look into that low category.
Mm-hmm. So as per the guidelines, also it's recommended to consider use of, anti-HER2 or even endocrine therapy. Look for the receptor positivity in at least one biopsy, regardless of the timing. So it may be current biopsy, and as Dr. Paulo also said, any biopsy, even the archival tissue, could be re-looked at. So we have a consensus there. So even in this Destiny Breast 4, yeah. So because
yeah, ma'am, if I could.
Yeah, sure, Ruchika. Yes.
Yeah. Sorry to interrupt. Just one thing I could have just add. When we do these repeat testing, what I've seen is, and what really helps is, if I see that there is a change in the HER2 status, or maybe for that matter, even an ERPI status, it is always a good idea to go dig back your slides, see what was originally reported. And it really helps. It really helps. Discuss it with your oncologist, because we know 5 to 10% cases, there can be a shift of your ERPR or a HER2. So I think that is a good practice for pathologists to include that.
How long the archival tissue, how long do they remain, good enough in quality to be able to...
So ma'am, the HER2 testing, they say that ideally it should be, one should not cut slides and keep it, because beyond 6 weeks, the antigen retrieval starts subsiding or starts fading. So what we do is we don't cut slides and keep. So as and when the test comes, one cuts the slide and then performs the test. Because over time, the antigen retrievability is lost.
Right. So you go back to the blocks, not these slides, right?
No, the slides, no, once the testing is done, then the slides are there.
Okay,
once we've done the test, you can see the slides. But like there are some labs where HER2 number or ERPR number is low. So they cut slides in batches and keep them. And then they'll say, okay, after 2 weeks, we'll run all the ERs together or all HER2s together.
All right.
So that practice, not much, but remotely that practice still happens. So that should be discouraged. That is it. But slides, once you've done the staining, they are there. You can, retrieve and...
All right. Okay. So coming back to this case, this patient, since was hormone receptor positive and HER2 new 1+ in 2022, she was planned for CDK4/6 inhibitor with fulvestrant. So Abema with fulvestrant was given, and she again progressed on that when she was given capecitabine. However, within 3 months of capecitabine, she again progressed. So what next? I think the answer is clear, but Dr. Vineet, you could take this.
Yeah, so first of all, as Dr. Paulo mentioned, we should have the NGS report by this point, because we might want to look at all the targets. But NR2 is the low-hanging fruit. Patient fits the criteria for the DB4 trial. Patient received 2 lines of hormone therapy, 1 line of chemotherapy, and undergoing progression. So I think probably we would go for NR2 since patient is HER2 1+.
So just one question to Dr. Paulo, if he could take this. So suppose, as Dr. Vineet mentioned, we need to have NGS here, and suppose we happen to find PIK3CA mutation. In that case, what would you choose? Or even say 2 lines earlier when she had failed abemaciclib with the fulvestrant, and you had this PIK3CA mutation, would you have offered alpelisib, or would you have offered Enhertu, TDXT?
So it's an important question because, as I mentioned, usually we try to to give more than 1 line of endocrine treatment, and now we're having several agents that can help to do so. So, for instance, for a patient with a PIK3CA mutation, now recently the FDA approved capivasertib, which seems better tolerated than alpelisib from cross-trial comparison and pretty active. So usually we consider doing that, doing like endocrine treatment and capivasertib, but it depends also on the pace of, let's say, progression of the tumor. If the tumor seems not very endocrine sensitive, in that case, I prefer moving on to chemotherapy, like capecitabine. And after capecitabine, I really think TDXT in this case is the best treatment. The only thing is that when there is only bone progression of disease, I try to do my best to always confirm if it's just actually a response of disease, because sometimes in the bones it's very hard to decipher. You can have, more sclerosis, and maybe it's a response instead of a progression. But if the progression is confirmed, I think TDXT is the best option.
Right. So why we say is based on the Destiny Breast-04 trial, wherein improvement and significantly so was seen in the progression-free survival in both hormone receptor positive and all irrespective of the hormone receptor status. There was also significant improvement seen in the overall survival, and there was 31% reduction, in fact, in the risk of death in the TDXT arm compared to the treatment of physician choice. So Dr. Paulo did mention in his talk as to how to sequence and which agent to choose between TDXT and sacituzumab. So for HER2 low status, let's hear now Dr. Paulo did mention, and Dr. Chandragowda, you could take this. What would be your sequence,
HER2 low category.
HER2 low, yeah, between TDXT and since we also have another ADC.
I would, yeah, so sacituzumab in a triple negative breast cancer, I would place both the TDXT. So Sasu has better. So sacituzumab I would place, and then I would move on to TDXT after that.
In triple negative, but in HER2
Yeah.
low?
HER2 low, we have data, then I'll place the TDXT up and the sacituzumab down.
Right. So even though cross trial comparisons have to be avoided, but if you see here in this situation, the Destiny Breast-04 and Tropics-02, you would see here that the hazard ratio and the results with TDXT in terms of median PFS are much superior compared to sacituzumab. So obviously we would sequence TDXT sooner than sacituzumab. And would you, in a case like this, would you have re-challenged this patient with another CDK4/6 inhibitor, Dr. Vineet? Since we have Maintain and the PACE trial, would you have considered re-challenge rather than shifting to TDXT, or how would you, clinically decide?
Yeah. So yeah, the problem is that the patient is out of options for the hormone therapy partner. So we don't have, elacestrant or camizestrant. They are not available. We just have,
Right.
tamoxifen aromatase inhibitor and fulvestrant, and patient has failed, fulvestrant and one line of CDK4/6 inhibitor. But yeah, so if suppose we have a patient who has taken frontline, say aromatase inhibitor and CDK4/6 inhibitor, and patient doesn't have, maybe a PIK3CA pathway alteration, then probably second line I would not be averse to giving fulvestrant along with ribociclib, like it was given in the
Like
maintain trial.
maintain,
So
yeah.
yeah, but probably not in this patient. But yeah, so that would be a consideration for some patients.
Right. Dr. Paulo, if you could take this, so would you base this decision of re-challenge with CDK4/6 inhibitor versus TDXT, would you base it also on the tumor burden or the visceral involvement or that kind of thing?
So yes, I think that's a key consideration. We don't do this so often. We do this rarely because there is no phase 3 data. The data is heterogeneous. But imagine if a patient has responded extremely well to first-line CDK4/6 inhibitor for years, and then there is a very minor progression in a bone metastasis, and the patient has tolerated the treatment well. I think it's not crazy to consider this. For instance, the maintain trial that we see here found positive results. But with more and more options that are becoming available, I think I tend to prefer other options. So this is one of the options, and we still offer it to selected patients, but just selected patients. It's not something we do so often.
So what if this patient was germline BRCA mutated? Dr. Chandragouda?
If a German, then think we need to go for olaparib in this setting. So no doubt on that. So because that is what the molecular directed therapy, and then probably have data on that olaparib irrespective of lines.
So Dr. Paulo, between these two PARP inhibitors, olaparib and talazoparib, do you have any preference or?
I wouldn't say preference. I would say I have more experience with olaparib. That is the reason for which I use it usually. But I expect the activity of the two to be very similar. And in the trials, it was very consistent, both in a metastatic setting. Indeed, there is some data with both in the early setting, but only established with olaparib. So I think olaparib has got more data in support. I have more confidence, and this is why I use it. But I think talazoparib is also an option if it's available.
Right. So coming towards the end and some last question. Will HER2 IHC levels matter in the end for TDXT? I think I could ask Dr. Paulo your comments about these questions, the current knowledge gaps.
I would say yes and no, meaning that we are finding that they matter, but we are finding that also patients with very low HER2 levels can benefit to some extent. And so I think we need to clarify better this extent. We need to find better assays to dissect the responsiveness. But in the end, probably even HER2 zero patients will benefit. We need to wait for the data. But I think there is some suggestion in the DAISY trial and also in our real world cohort. So in the end, IHC levels will matter to some extent, but many more patients will benefit.
So do you think it may be offered ultimately to even IHC 0?
So there is this
Low,
trial.
ultra low, less than ultra low also?
I think so. I think so, just because it's so complex. There was this very interesting autopsy study that they did in Holland, where they found that in the same patients in the same liver had got some lesions that were too low, some others were ultra low, some others were zero. So it depends a lot on where you biopsy. And so there is so much variability that I think it's impossible to cover all of the tumors with one biopsy. And we need to kind of understand what happens if we use TDXT also for real zero, HER2 null. My sense is that there will be a benefit also there. The issue is that, is it more convenient to do TDXT or Dato-DXT or sacituzumab or something else? And there we need more trials. There are some ongoing. There is one that is about to open at our center that is called Trade-DXT that will test in the patients randomized to TDXT or Dato-DXT, and then at progression, the opposite ADC to try to compare, targeting, giving the same payload with the different targets, and we will see. So I think in the future, some more complexities will arise, but I think there will be a role for TDXT also for ultra low and maybe also for HER2 null.
Right. And the last question also to you, if you could share your viewpoint. What if the TDXT has to be stopped either due to disease progression or due to toxicity? What's your go-to drug in hormone receptor positive patient?
So this is a major clinical question because it happens, at least 10% of the patients, probably more. And in general, I consider the response that the patient achieved. If the patient achieved a very good response with TDXT, that usually is the case, I tend to consider maintenance endocrine treatment, maintenance AI, or sometimes fulvestrant, depending on the setting. But if instead the patient had only a stability of disease, maybe it's a high-risk disease with visual involvement, in those cases, I tend to prefer starting a new line of chemotherapy because I don't feel confident that I can maintain the patient safely on endocrine treatment. So it depends on the case, but if the patient responded well, that in most of the cases is the option, I will give endocrine treatment.
Right. Thank you. And thank you, Dr. Paulo, and thank you, my panelists, Dr. Vineet, Dr. Chandrakoda, and Dr. Ruchika, for your inputs. Thank you. Back to the organizers, please.
Thank you all. It was a pleasure.
Okay. Thank you, Dr. Paulo. So I'll just take this opportunity to thank you for giving us time and so many insights on sequencing of the therapies. And also a big thanks to Dr. Jyoti ma'am for wonderfully moderating the session. And also I'd like to thank our program director, Dr. Ashok Vaid, for being here and guiding us with the program. And also our chairpersons, Dr. P.N. Mahapatra and Dr. Kaushal Kalra. And thanks to all of you, and thanks to all the esteemed faculties and the audience who have joined. So I think I can give it back to Ankit if you would like to close. And
Yeah. First of all, Dr. Jyoti ma'am, sorry for mistakenly taking your hospital name wrong, and and thank you to all the faculties, esteemed faculties, and the sponsored pharma persons for making this webinar such a successful one. And with this, I would like to end the session. Thank you, everyone.